Hello and welcome to today's podcast. My name is Preeti Minhas and I'm the Assistant Director of Clinical Learning. We're seeing an increase year on year with people with heart failure. And this year, the British Heart Foundation reported that around 80% of heart failure diagnoses in England are made in hospital, despite 40% of patients having symptoms that should have triggered an earlier assessment. And it's totally estimated that more than 900,000 people in the UK have heart failure, with around another 200,000 new diagnoses of heart failure every year in the UK. So with these critical statistics, it's really imperative that we start to build on the knowledge and skills that we have around heart failure so that we can continue to support people living with heart failure live more positive lives. So as part of our Heart Failure podcast today, we are delighted to be joined by Jim Moore and Louise Clayton, where we'll be discussing optimizing heart failure care in primary care. So welcome, Jim and Louise. And just before we begin, we could talk a little bit about the roles that you currently have within heart failure.
Would you like me to go? I'll go first. Okay, so Jim Moore, I'm a GP with a special interest in cardiology, but particularly in heart failure. So I have for over 20 years worked as a clinician in the Gloucestershire Heart Failure Service. I'm currently the president of the Primary Care Cardiovascular Society, and I also support some of NHS England's work within the cardiac transformation programme, ostensibly providing a primary care perspective to the cardiac transformation programme, but also very much involved in the heart failure work stream.
Thank you so much. And it's great to have you here for you to share your insights and expertise. And I know we did a podcast last year as part of World Heart Day as well. So thank you so much for coming on. And Louise.
Pleasure.
Yeah, thank you for having us back. That's always a pleasure. So yeah, I'm a heart failure specialist nurse, ANP, based in Leicester. I'm the service lead here, and I also have a cardiac network lead role for heart failure in the East Midlands. And I also chair the National Alliance for Heart Failure policy making group as well. So I think heart failure between myself and Jim keeps us pretty busy.
Thank you so much for coming on to this podcast. And it's great to have that insights from both primary and secondary care, because it really provides us with a full view of the patient journey. So I'll hand it over to you to start to talk about the annual check of heart failure.
Thank you very much, Preeti. And I must say, it's always a great delight to have the opportunity to talk to Louise in such situations. So it's great to be here. Yeah. So how can primary care contribute most effectively to the care of people with heart failure? We're going to talk around a number of areas today, and picking out those particular parts of the heart failure pathway where we feel that primary care can help most. And I suppose when you think about pathway, it's better to start at the beginning and focus at the beginning, which and where there's a really, really important role for primary care. And you in fact, highlighted that in your introduction, Preeti, and that's around diagnosis. The evidence currently tells us that somewhere around 80% of heart failure diagnoses are made acutely within hospital, and that in itself is quite important, because again, as you highlighted in your introduction, the report from the BHF indicated that many people were presenting in primary care with symptoms of heart failure, yet those were not being, the early identification, those opportunities to make an early diagnosis were not being taken. And we have, there's a paper back in 2018 by Alex Bottle published in Heart Journal, which showed just that. It was a study that looked at the follow-up of people in primary care using primary care records, follow-up people presenting with heart failure symptoms and looking at what happened to them. And somewhere around a half of those individuals presenting with symptoms of heart failure did not follow an established pathway in terms of early diagnosis. We know that if the diagnosis of heart failure is delayed until someone's admitted acutely to hospital, then the median survival, so that's the long-term survival, is halved. So an early diagnosis of heart failure means the median survival is doubled. And that's why it's so important that when people present, we think heart failure and we investigate them appropriately. And what's key to that investigation is the test, which is widely available to primary care, the measurement of natriuretic peptides, the measurements of NT-proBNP, which helps us to identify those people who are very unlikely to have heart failure, and thereby identifying those who may have heart failure and need more urgent investigation. And I'm sure, Louise, you will have a similar experience to that I have working in a heart failure service, where we see an individual who has presented to primary care where it's not really, the impression is it's not been thought early enough. The diagnosis of heart failure has not been thought early enough commonly. And you can understand why it's not thought about early enough, because, you know, certainly in the last few years, particularly, we've been focused around COVID, around respiratory problems. So there's almost that kind of natural, our instinct takes us towards that in an initial diagnosis of someone presenting with breathlessness.
Yeah, I think you're right, Jim. I think the important thing is, as we know, access to NT-proBNP nationally is actually quite good. You know, we've got fairly good data on that now. But as you've just highlighted, some of the problem actually is once people have even had that initial thought and arranged an NT-proBNP, the pathway then for the patient to begin that journey is very disparate across the country, isn't it? You know, some areas we're just not getting people to specialists quick enough. Some areas we've not got that joined up thought process, like you say, from NT to echo. And that was exactly what the bottle paper showed us, wasn't it? The pathway was really quite different for a number of the patients. And I guess that's one thing that we really want to sort of get the message out there is, you know, speak to your local teams, speak to the ICB CVD leads, you know, and let's kind of get that high up on the agenda to make sure this pathway part, not just the access, but the pathway part is actually sorted out a lot better.
So important, Louise, and in many ways, it's the heart failure pathway doesn't need to be complicated. It doesn't. It needs that there are some key points within the pathway. So the initial thing is just thinking heart failure. Someone in front of you, they've got breathlessness. Ask them about ankle swelling. Have they got ankle swelling? Have they got fatigue? So your classical triad of symptoms. And then if they have, there are other questions that can be quite useful to ask, particularly around breathlessness and lying flat. So two questions. One is orthopnea. Do you get breathless when you lie flat? Or are you waking up during the night, having to sit up to get your breath? If you've got either of those two symptoms, they are much more specific around a diagnosis of heart failure. If they're there, if you're suspicious, do an NT-proBNP. Your local lab should tell you if that NT-proBNP is normal or abnormal. We do work on this kind of figure of 400 picograms per mil. I'm trying to remember I should know because I was on the NICE guidance when we discussed this. But 400 picograms were low. If it's below that, it's unlikely to be heart failure. It doesn't mean it absolutely isn't, but it makes it very unlikely. If it's above that, the responsibility of primary care is get on and refer that person urgently. You'll see within guidance, in NICE guidance, it talks about ranges of NT-proBNP, 400 up to 2,000. Someone should be seen and assessed, have an echocardiogram within 6 weeks. If it's above 2,000, then 2 weeks. And that's quite difficult in current situation because of echo availability. But the key thing for primary care is you don't need to decide around the 2 weeks and the 6 weeks. You simply need to refer that individual urgently. In an ideal pathway, we will have specialist triage. You provide information about the patient. Hopefully you can provide an ECG, you provide symptoms and background information, and then a specialist, a heart failure specialist, should be triaging that information and deciding how soon further investigation should take place.
I think it's really important. One of the issues you just raised there around that this is actually really quite simple as far as some of the questions. I think, you know, if we're seeing somebody in any clinic in primary care, you know, we don't need to be necessarily in the, you know, the urgent GP list of the day. You know, let's think about practice nurses, pharmacists that are out there seeing patients. You know, it might be in the diabetic clinic, or it might be for the hypertension review. This doesn't need to be a big piece of work with a big template, does it? It just needs to be some simple questions, you know, whilst you're having a chat about the diabetes. Have you had any problems with your breathing? Have you had any concerns recently? You build it into your chat. That's all we need to do. If that patient actually does have some symptoms in one of the common comorbidities that we know are linked to heart failure, i.e. diabetes, hypertension, ischemic heart disease, then just arrange that NT-proBNP, like you said. If they haven't got any of those symptoms, we don't need that NT-proBNP. We're not adding to the cost of primary care budgets, that's for sure. But if the patient just happens to sort of be chatting to you and say, you know, that they've been struggling to walk the dog around the local park recently, interesting that you should ask that, nurse, thank you very much. Add that blood test to your annual diabetic review. That's, you know, that starts that pathway straight away, doesn't it?
Absolutely beautiful segue, Louise, into that area of long-term conditions. And we know, don't we, that a typical heart failure patient is older, usually somewhere upwards towards 80 years old, with someone looked at the comorbidities, those common comorbidities, 5 to 6 common comorbidities, which makes it more difficult to manage these people. We know in our heart failure clinics, from our experience, Louise, how much more difficult it is if they've got CKD or if they have, you know, atrial fibrillation, etc. But it's about opportunity. You're absolutely right. If you look at your typical heart failure patient, somewhere around a quarter of them will have diabetes. Conversely, if you look at a population of individuals with diabetes, and there are some very good publications around this, if you go looking for heart failure in a population with diabetes where there's no heart failure diagnosed previously, somewhere around a quarter of these people will have heart failure if you go looking for it. And one of the things we're trying to encourage in primary care to identify people with heart failure earlier is that to the templates that we commonly use in long-term conditions clinics and primary care, and typically it's a wonderful practice nurses who are actually doing these reviews, and in fact, clinical pharmacists within primary care are now doing doing increasing numbers of reviews. But it's the templates that are being used in long-term conditions clinic. We're encouraging people to consider adding questions around heart failure, just around breathlessness, just around peripheral edema. And if these have appeared or exercise tolerance has changed, then asking a few additional questions and thinking about NT-proBNP. So you're absolutely right. These are where many of our patients exist. We should be opportunistically, hopefully, identifying them within that situation. And really, it doesn't add much work to primary care. We know it's, you know, the environment in primary care is difficult currently. You know, we don't have the resources we should, but it doesn't add to that.
I think
so thinking about, sorry, please.
I was just going to say, coming back to this, you know, we keep mentioning this opportunities, don't we? I think that's the key word of today's podcast, to be honest. So we've had another, obviously, opportunity this year with the rolling out of the breathlessness pathway, which obviously you just mentioned. Now, we know about the complexities and the sort of the non-specific symptoms sometimes that heart failure patients report. And as you said, over the last few years, particularly, instantly breathlessness makes you kind of go down that respiratory route rather than heart failure necessarily. But if we kind of take a step back and think about the breathlessness pathway, that actually leads us quite nicely to think about the broader potential diagnosis within that. And I think certainly in primary care, if we can set up prompts for the breathlessness pathway during assessments, that's certainly something I'm aware that some ICBs have been looking at, to set up that prompt for the word breathlessness. And then, as you say, those assessment templates kind of can pop up then, which makes us think about, could this be heart failure? So I think that's another invaluable opportunity that we need to embed.
Indeed, and so the breathlessness pathway that Louise has just highlighted, NHS England have just published an NHSE breathlessness pathway, which you should be able to access, and it's really quite useful, particularly in situations where you're struggling to find a diagnosis for an individual's breathlessness. So thinking about other opportunities, Louise, within primary care, of course, there is now a cough indicator based around an annual review for people on our heart failure register within primary care. So, I saw this as an important watershed. I saw this as recognition that heart failure in primary care had become a long-term condition. In the same way as we, COPD and diabetes, we review those individuals. Heart failure had finally joined that group. And the requirement, according to QOF, and if I'm correct, I think it's HF007, is that we should be doing an annual review, which includes some assessment of functional capacity. So, change in exercise, particularly, change in exercise capacity, that dynamic change. Are you no longer able to walk up to the shop to get your paper in the morning, etc., or is taking the dog a walk, as you've indicated previously, creating more problems? So that's the sort of thing we would ask about. But it's also about a review of current medication and whether that medication is optimized. We won't go into the details necessarily of this today, but we know across the heart failure spectrum, whether we be talking about heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, or the bit in between, heart failure with mildly reduced ejection fraction, we know there are now evidence-based therapies for all those groups. And what the annual review does is it presents an opportunity to actually review medication and see if those individuals are actually on the relevant medication.
Absolutely. And again, linking back to what we were talking about earlier around that pathway and ensuring that the pathway is in place. At that annual review, if things are picked up and, maybe medications are not quite optimal, or the patient's having some worsening symptoms, it doesn't necessarily mean, an urgent referral to a specialist service. As we've already said, a lot of these patients are living with multiple comorbidities. Actually, I think the important bit is making sure that we've had that conversation with the specialist service in your local area. Have you got advice and guidance set up, for example? Is there an MDT that primary care can access? This is a much better way of managing this for the patient, isn't it? If we can actually pick up something at the annual review. That's what they're there for, after all. Seek some advice and guidance, and then manage the patient closer to home. This is exactly, this is the sort of the teamwork and the approach that we kind of want to have set in place for all areas in the country. That's a bit of the utopia, I think, that we're aiming for at the moment.
It's also in what you've said, Louise, there's that recognition that there is complexity within heart failure, and there may not be the skills, the confidence, or the experience within primary care to be able to feel that you can safely manage those individuals. And that's where, as you describe, either using advice and guidance, using your, talking to, communicating with your local heart failure service is quite important. I suppose one of the things I think increasingly we are seeing in pockets around the country is that primary care is taking on some of that work around titration or introducing medication with oversight from the heart failure team. So it doesn't mean that you're left alone in isolation to do that. You have some support that's there and remotely able to do, to help. And the other thing to just to highlight is if you are doing a review and you have someone who has symptoms, I mean, we automatically think, okay, so it's a deterioration in their heart failure, as opposed to, oh, well, they might have gone into another heart rhythm. They may be they've maybe gone into atrial fibrillation, or there may be other reasons. And that again is where it's quite useful, I think, to have that contact with the specialist team.
Absolutely.
But an important opportunity. And one of the things I will just highlight is how I think there are greater opportunities for primary care to be supported to manage people with heart failure, not least with that really potentially invaluable resource of clinical pharmacists within primary care.
And I think that leads on really nicely to the other point that we just wanted to mention briefly today. Was, I think for me, it's very much around, don't be too concerned about the specialist notion of treating heart failure. We've just talked about all of the comorbidities that these people are living with. We've just talked about the symptoms that they're experiencing and the fact that they're already seeing healthcare professionals in primary care. Many of the medications that we use are actually already in use for many of the other conditions. So we shouldn't be frightened of them. The medications are there. They're there for diabetes. They're there for hypertension. They're there for ischemic heart disease. They're equally excellent in heart failure management. So I think, we can use, again, the opportunity word, when people are seeing patients in primary care, we can access a lot of the medications with advice and guidance and with support, like you say, but actually it crosses that whole spectrum of heart failure, but also the spectrum of the sort of conditions that they're actually living with.
Yeah. And it's that, again, that nicely segues into just talking about treatment of heart failure, the modern treatment of heart failure. So, when as part of the NICE guideline committee that published the chronic heart failure guideline in 2018, we were very much looking around classical pathways of introducing medications, up titrating them, and then introducing in a sequence. So we'd start with drug A, we'd optimize it, we'd then introduce drug B, and before you know it, 6 months had gone. And one of the things that we've seen in the evidence over the last 5 years and previously tells us that it's really important to get the evidence-based medicines into place more quickly. 6 months, much too long. We know that many of these drugs will provide benefit, statistical benefit that we see in the research from 4 weeks onwards. So you will see from people who are being seen in heart failure clinics a change in the way we approach particularly the therapeutics in these people. There's also a realization that although we've discovered drugs in a specific order over the last 20 or 30 years, and we've used and introduced these drugs in that specific order, there's no evidence that necessarily supports that that drug that we identified at the very beginning, in the 1980s, is any better than the drugs that we've identified as being helpful in the last 4 or 5 years. So the approach is different towards people with heart failure. We choose the drugs that are very much appropriate to the individual and what they present to us, as opposed to going through a classical sequence of drugs. One of the most recently introduced group of evidence-based therapies are SGLT2 inhibitors. Very easy to use, very well tolerated in the majority of patients, and drugs which don't typically significantly affect blood pressure or affect electrolytes, and in fact are very good in people with CKD, people who've got impaired renal function. They tend to blunt that deterioration that you've seen, and you may well be aware of that as well. So you may well see many more patients where we introduce drugs like SGLT2 inhibitors at the beginning of a pathway as opposed to at the end of the pathway. And of course, in people without diabetes, typically these are drugs that were introduced for people with type 2 diabetes to control their sugar. But we know both in people with diabetes and people who don't have diabetes that these drugs are terribly, terribly useful. Improve symptoms, they improve mortality, long-term prognosis, and they keep people out of hospital, all of which are very important.
So our key messages then, I think, opportunity, opportunity, opportunity. I think this is what we want, isn't it? Let's not have this 40% of patients who've presented to a healthcare professional with symptoms and then still end up being diagnosed in hospital. That's the bit we need to change, isn't it? Like you said at the very beginning, Jim, the quicker we can get to the patients, the quicker we can really make a positive impact on their lives. So that's the message for today, I think.
Yeah, absolutely.
And talk to your local services. Get to know your local heart failure services.
Yeah.
Well, that brings us to the end of today's podcast, and I'd just like to say thank you, both of you. We're talking so passionately about heart failure, as always. And I think it's fair to say today's podcast really focuses on not adding to the workload of primary care, but as Louise just mentioned, it's about identifying and utilising the opportunities that are at your fingertips to support diagnosis and the treatment pathways of those living with heart failure. Like we said, try to remember who's around you. The landscape of the workforce has changed dramatically over the last couple of years. We now have various roles, as Jim mentioned, as part of our multidisciplinary team. Again, gaining access to more specialist services that can support you, I think is really, really vital. And actually, if we start to utilise some of these opportunities around diagnosis and treatment pathways, we hope to reduce the regional variability of care within heart failure, which we mentioned at the beginning of the podcast. So again, thinking about the resources that are available to you, both Jim and Louise mentioned the clinical guidelines, such as the NICE guidelines, but also the pathways issued around the breathlessness pathway. Again, to support your knowledge and skills, we have a number of courses at Education for Health to support you build that expertise so you can really support your patients living with these conditions. And for more information, please visit www.educationforhealth.org. So again, I'd like to take this opportunity to say thank you to both Jim and Louise for joining us today. And we really hope that today's podcast has supported you to starting to think about some of those opportunities that you have to hand to utilise that can really support people living with heart failure.
Thank you very much, Preeti. Nice to see you.
Thank you.